Mr. Chairman, dear colleagues, I'd like to thank the Society for inviting me to talk about the latest development of ERAS in urology. My presentation will be articulated around four main questions, and I'll tell you a bit about our initial experience in Lausanne, Switzerland, while implementing ERAS in our urology department, and I'll discuss some of the pitfalls we encountered. And finally, I'll talk about the future perspective of the ERAS Urology Group, and finally, the conclusions. The first question is, ERAS, does it have a place in urology? Well, I believe the answer to this question is yes. You all know that as soon as there is a significant surgical stress, such as after major surgery, there is a role for ERAS, so I believe urology is well in place here. What do we want to achieve by implementing ERAS in urology? Well, pretty much the same as our colleagues from colorectal surgery. We want to decrease morbidity, we want to decrease the bowel recovery time and the length of stay, even though I personally think that length of stay should not be considered as an outcome, but rather as a consequences of the two former outcomes, and we should rather concentrate on other outcomes such as pain, patient satisfaction, disease-free survival, and mortality, which are, in my view, much more important than length of stay, which is completely dependent on healthcare system and institutions. So having that in mind, what are the major urological procedures that could benefit from ERAS? Well, certainly cystectomy, which is one of the most morbid surgery in all domain, and for sure radical or partial nephrectomy, at least opened. And I put radical prostatectomy between brackets because, as you know, nowadays most of these procedures are performed using minimally invasive surgery like laparoscopy or robotics, and the surgical stress is minimal. People stay 1 or at maximum 2 days. Complication rate is low, so I'm not sure about the real benefit of an ERAS protocol in these patients. For retroperitoneal lymph node dissection, it's a major surgery, but nowadays they are rarely performed, especially and just in excellence and reference centers. So it's not widely applicable. So I'm not sure again if developing an ERAS protocol would be widely accepted. And transvesical endomectomy, it's an old procedure nowadays with new technology, especially endourology and holmium laser. They are less and less performed, so again, I'm not sure we need to invest much time in developing ERAS protocol for this type of surgery. So which patient can benefit from ERAS? In my view, the patient with the highest potential for reduction of surgical stress is a good candidate. Usually comorbid elderly patients undergoing major open surgery have a higher risk of surgical stress, high risk of complications, and a prolonged length of stay. So these are the good candidates, and ladies and gentlemen, this is the typical cystectomy patient we encounter every day. So what about the people that undergo minimally invasive surgery? That's a good question, and our colleagues from the colorectal surgery have answered this question with a nice study, which you know better than me, the LAFA study, which showed that the combination of laparoscopy and ERAS program was the best strategy for a patient undergoing colonic surgery. Is that true for a urological patient? Well, there's 3 studies actually, one considering a robot-assisted cystectomy. It was a non-randomized study, including 31 patients in the ERAS group, which was a partial ERAS, only using 11 items out of the 22 usually required. And they didn't show any significant difference as far as length of stay, morbidity, and bowel recovery are concerned. The second study, they randomized patients undergoing laparoscopic radical nephrectomy, 13 patients in the ERAS group, including 8 items, and they showed a decreased pain level and length of stay, the other outcomes were similar. And finally, for radical prostatectomy, laparoscopic, they randomized 25 patients in the ERAS group, which again used 8 items, and they showed decreased pain, length of stay, and bowel recovery time. So we can conclude that yes, they could be a potential benefit using ERAS in minimally invasive urological procedure, but the benefit seems marginal, and this might be explained by the minimally invasive surgery, which reduces the surgical stress so much that the other ERAS items might be marginal. You all know this slide. We've seen it a couple of times. The question is, do the colorectal recommendations apply to urology? Before I answer this question, for those who are not familiar with urology, I would highlight some of the main differences between colorectal surgery and cystectomy. First of all, it's a multi-compartmental surgery. We go intra, extra, and retroperitoneal. Usually the operative time is much longer, 5 to 7 hours, depending on the reconstruction we use. There is an increased risk of bleeding with transfusion rate of about 20%. And depending, well, usually you cannot avoid some of urine within the peritoneal cavity, which can then cause infectious or chemical peritonitis. And we have 3 anastomosis, and also the patients, some of them come before surgery with pre-existing renal insufficiency due to tumor obstruction. So these are not the same patients as in colorectal surgery. The physiology is completely different. As for nephrectomy, of course, there is an increased risk of bleeding if we consider partial nephrectomy. The renal insufficiency is one of the risks, especially in radical nephrectomy. And again, for partials, if we open the collecting system while removing the tumor, there is a risk of urinary leakage. So do colorectal recommendations apply to urology? I would say yes, because most of the items are applicable to urological patients. But no, because we need pathways that are tailored to every single urological procedures. And we might need to redefine the goals as far as drains and tubes, fluid monitoring, early oral nutrition, and mobilizations are concerned. And also for many of these items, there is weak or absolutely no evidence for the urological population, so we just assume that these colorectal guidelines could apply. Let's take a closer look at radical cystectomy. So we wanted to know what was the evidence behind every single ERAS items for these populations, and we performed the systematic review last year, including 15 studies, actually 11 single intervention studies and 4 multimodal studies. Here they are. So we only included randomized control trials and prospective studies. As you can see, the JADAT scores are quite low. That's the studies items, and this is the intervention. I don't want to go into much detail, and the only message I wanted to give you is that actually almost all of these single items showed beneficial effects in one of these 3 outcomes that are usually used. But as far as morbidity is concerned, only perioperative fluid management and avoidance of bowel prep showed a significant effect. So one of the items merits special attention, and that's minimally invasive approach. There is an international consortium, and they have included almost 1,000 patients now undergoing robotically assisted radical cystectomy. Unfortunately, there is no comparative group, but they have shown that the complication rate at 30 days is 41%, which is actually very low for a cystectomy. Usually it's around 60 to 70% when we use a valid classification. So this might be something we need to look at closely. So this is the biggest piece of evidence so far. It's published recently in January this year. Comes from California. They included all consecutive patients undergoing open radical cystectomy in an ERAS pathway, and they compared these patients to matched retrospective controls. They use a full ERAS, but there were some differences, actually major differences, such as Analgesia. They didn't use epidurals. Instead, they use a per-incisional sub-Q catheter and IV ketorolac. They stimulated bowel with alvimopan and neostigmine, and they had a prolonged use of antibiotics for 3 weeks, and they were allowed to get IV fluid back home, so they were kind of discharged in a medically facilitation, which is not really home. Anyway, they included 110 patients, and they showed an impressive length of stay that was much shorter in the ERAS group, from 8 to 4 days. And again, this is not applicable to European centers, I think, because we don't have the same healthcare system, and we cannot give perfusions to our patients when they're back home. They didn't show any significant difference in bowel recovery complication rate or readmission rate, which was quite high, by the way, 21%. In Lausanne, we started in October 2012, and it took us quite a lot of work and quite a lot of time to get started. We have included 30 cystectomy patients so far with no selection. We compared them to 50 retrospective pre-ERAS patients, and we were not able to show any significant differences in length of stay, bowel recovery complication rate, or readmission rate. So of course it's too early to draw any conclusions. We need to include much more patients and to merge the databases from other centers to get the number, to have robust data. But we still kind of looked on the reasons why we didn't show any difference, and one of the explanation could be the compliance. As you see, we are quite good at compliance with pre- and intraoperative ERAS items. It's an excellent 92% compliance, even though before we started ERAS, we already had a 40% compliance. So this might introduce a bias in the comparative group. But as you can see, the compliance with post-op ERAS items is very low, 47%. Actually, it's more like 60% because there are some items in the database that we cannot comply with because it's not tailored to urology. So it adds another 15%. So anyway, 60% is too low. So is this a question of resources, of motivation, or feasibility, and who is responsible for this non-compliance? This is an open question, and we'll look at the data more closely to get an answer. But I think this picture summarizes well these three main questions. So as you can see, it takes quite a lot of resources to mobilize a patient at day 0 or day 1 after a major surgery such as a cystectomy. It takes 2 nurses, and I bet these nurses have much work to do with other patients, so they might be less motivated to walk around the corridors with the patient. And is it feasible? Can we ask a patient after an 8-hour-long surgery to walk? So these are, again, open questions we'll need to answer, and we'll need to tailor the pathway for these patients. I'll emphasize once again the mandatory role of an ERAS dedicated team, and the ERAS nurse, I think, plays a major role in this team. So I'll take this opportunity to thank my team for the tremendous amount of work that have been done during this implementation. Another pitfall we encountered while implementing ERAS at our institution is a high rate of ileus despite a good compliance with the items that are supposed to reduce the rate of ileus. I didn't wrote higher because it was not higher than the control group, but still high. And we were a bit disappointed because we had great expectation by using goal-directed fluid therapy. We managed to be quite restrictive, decreasing the amount of fluid by 20%. Gum chewing was a pretty good compliance. We used multimodal P1V prophylaxis and laxatives, and of course early mobilization. The compliance was not very good, but still a high rate of failures. So I think the point of this meeting is to exchange with other experts, and we have that urology group, and it's always good to talk to other people that are faced with the same problems, and some of them have found solutions, so we'll apply it back to Lausanne in the future. Let's talk about nephrectomy. So again, like for a cystectomy, we want to take a look at the data, and there is an ongoing collaborative review. We'll use the same pattern as for cystectomy, so we'll go items by items and multimodal. So far we have identified 5 major studies, 3 randomized controlled trial and 2 prospective studies that use multimodal protocol. They include 6 to 16 ERAS items, so it's not a full ERAS, but as you can see, the patient number is very low, 114 ERAS patients in 5 studies. So, and they were able to show a decreased length of stay, but the other outcomes were not very conclusive between the studies, so we need more robust data. In Lausanne, we've started about at the same time as for cystectomy. We included 58 patients, and mainly open nephrectomies. We compared them to 51 pre-ERAS controls. We've shown that the length of stays was decreased from 8 to 6 days. They had a shorter bowel recovery time and decreased complication rate from 58 to 31%. So it's good results, very stimulating. Plus there was no increase in readmission rate. So of course we'll again need to include more patients, but these are quite motivating results. And we need also to adjust for slightly higher proportion of laparoscopy in the ERAS group. So again, this question of minimally invasive surgery combined to ERAS. What about the future perspectives of ERAS in urology? I think the future is bright. As we can see on this picture, the key word is collaboration. We have small numbers. We really need to get together. We're pioneers, so we don't have the answers, and we need to discuss together. There's already a couple of university hospitals implementing ERAS in urology, so we really need to get together. There are many more people that are ready to join our group once our database will be tailored to urological procedures. And so far there is 3 centers that are using the database. We have about 380 patients, 270 cystectomies, and 109 nephrectomies. So it's looking good, and it's growing fast. We just need ethical approval in order to publish this data, but it's going to be robust data and good quality, standardized. So I'm really looking forward to move on with this ERAS urology group, which also I thank today for their work. Again, there is a collaborative review ongoing. We have that parallel ERAS urology meeting. The first year, actually last year, there was 7 of us. 2 days ago we were 16, so we can expect about 30 people next year, hopefully. And there is much work to do in tailoring the database for a urological procedure. And once this will be done, we can merge the database, audit our data, publish, and increase our visibility. We can summarize the future of ERAS by saying it's ERAS. E means expand the program worldwide, get as many centers as possible to join us. R for refine the protocol for each urological procedure. We need to redefine the goals and some of the items so that the protocols can be implemented in this population. audit our results. Of course, it's always good to audit, and I didn't have the iceberg picture, but I have the mirror one, which you have seen a couple of times. So we really need to make sure that we're doing the right thing and ask ourselves what we are and if it's really what we are. And finally, S, we need to show that ERAS is working. So far, the evidence is quite weak. So again, we need robust data to show the benefits. In conclusion, ERAS has a place in urology, especially for major surgeries such as cystectomy and nephrectomy. We'll see about minimally invasive surgery. It at least reduces length of stay, but I would like to see its impact on morbidity, which in my opinion is the main clinical outcome. Each urological procedure needs a special dedicated ERAS protocol, and of course we need standardization and collaboration in the future to get this robust data. I thank you for your attention, and if you have any time to stop by in Lausanne, please do so. It's a very nice city.